Hi guys, this is Ramesh from the Ballarat Health Service. Sorry for the delay. It's wonders of modern technology, as they say. Now, this is a first for me because I'm actually speaking into a phone and my slides have come up on a screen in front of me. I'm 44 years old. I don't think I have the correct pair of spectacles, so please, if things seem a bit wonky when I read them out, don't take it out on me. So, I'm a neurologist. My primary interest is in stroke, but I've also had training in geriatric medicine. And that's the reason that my background or my speciality is sort of stroke or neurology in the elderly. Delirium is something that's very close to my heart, and it was a topic that was introduced to me by a geriatrician from Singapore many years ago. So, delirium in stroke, so what? And the reason that I've called it this is because I think that's generally the attitude that many people take, and I think it's something that very few people are actually aware of. So, let's start it off. So, this is the outline of what I'm going to be talking to you about. What is delirium? How common is it in stroke? Why is it important to recognize delirium? What are the risk factors and precipitants for this condition? And how do you recognize and screen for delirium before we go on to what we should do? So, what is delirium? If there are Neil Gaiman fans out there, delirium is not the youngest of the entities. Delirium is not also about pink elephants, which is something that's normally spoken about in people with delirium tremens, which is another form. This is perhaps the picture that you're more common with in the ward. So our delirium patients are those who are a little older. They may not be so old sometimes, but they're frail. So in terms of their physiological age, it's much higher than what it is on their birth cert. And mostly, they're there for a multitude of problems and on a multitude of medications. Our picture of our patients is fairly clear, I think, most times, but their picture of themselves is unfortunately not as clear, and it becomes very fuzzy for them in terms of why they're in hospital and what's going on around them. Now, this is my first question. So, can I have an idea of whether you've dealt with a delirium patient in the last month? So in addition to speaking to all of you, I've got my own audience here who are looking at me fairly perplexed because I'm talking into a phone and talking to them at the same time. We'll give it a while to sort of come in terms of the results. We've got a show of hands across the room here, everyone except for one. And let's close the poll. So with that, I think, yep, majority of the people listening in today feel that they have dealt with someone with delirium. I think roughly just now it was more than 2/3. So that's a good start, I'd say. So what are we talking about in terms of definitions? So delirium is part, excuse me, of the DSM-5, and in it there are 4 points or 4 categories. So there's a disturbance in attention, there's change in cognition, this is something that occurs over a short period of time, and there are points in the history. What are the salient points that we need to be sort of aware of? So I think the first thing that you need to be aware of is delirium is a deficit of attention and awareness. So this comes across as a reduced ability to direct focus, sustain, and shift attention. So how does this manifest? It manifests as your patient not being able to switch from one task to another if you're formally assessing them. There's also a change in cognition, and this could be memory, which it often is, orientation, but sometimes they also have problems with language or perceptual disturbance. And this is the reason that sometimes delirium patients come in and are mistaken as stroke, because they're labeled as either being dysarthric or dysphasic. One of the hallmarks of delirium is that it occurs over a fairly short period, and there's a tendency for it to fluctuate through the day. So your patient could be bright as a button 1 minute, and half an hour later, they are obtunded. And the main thing to remember is that there's always something underlying the delirium. So whether that's a medical condition, whether that's because they've come in intoxicated, not just on alcohol, but oftentimes on things like opioids and the rest. And the important bit to remember in all of this, it's that more often than not, it's not one single cause. So how common is delirium in stroke? Now, before we go to that, I think it's a question of how common is delirium in general. And in dealing with delirium, what you're usually looking at is 25 to 60%, but this really depends on patient factors like age and underlying disease, and clinical factors like what they're in hospital for in the first place. If you look at it with, say, a little more detail, delirium changes according to whether the patient is in the community where it's fairly low, or in the setting of a general hospital admission where it can go up to about 25%. Now, I think this 1 or 2% is probably an underestimation, because you're not going to be really looking for delirium in the community. The other important bit to remember is that patients who have who've gone in for operations and whatnot are at very high risk for delirium. And again, depending on which discipline, whether it's orthopedics, general surgery, you could have numbers as high as 50% of a population over 65 developing delirium. In the last few years, this has been an area of extreme interest, the patients in the ICU. And as you can see, the lower range there is about 70%. So that's a huge proportion of patients who actually develop delirium. I've noted that there's a comment about the sound is cutting in and out for us. The guys are looking at this. We've got people from the webinar service who are monitoring the situation as well. So hopefully it gets better. All right. Thank you, Karen. Anyway, to go back to what we were saying, how common is delirium in stroke? The reason that I put this paper up is because this was, again, one of my first introductions to delirium and stroke when I was looking through the topic a few years ago. This is a review paper, and their review basically showed that delirium ranged from 13 to 48% amongst the articles that they'd gone through. And of course, they then went on to do their own. And so when they did their own, they looked at a cross-sectional study of about 110 patients over 7 months. And delirium was found in 23 of these patients on first assessment. And when they repeated the assessment, it went up to 69. Again, I think this might be a little on the high side, but that's generally what we're looking at. The problem, of course, when you're sort of dealing with single-center studies is that there's a lot of bias. The numbers aren't very big usually. And so in something as poorly researched as delirium and stroke, you have to go on to the systematic reviews and whatnot. So this is a systematic review that was published fairly recently in 2012, and they looked at about 20 studies published all the way up to 2010, and these were specifically looking at delirium in acute stroke. The tools that were used to screen for delirium were fairly standard. This is something that I'll be mentioning later on in my talk. And what they showed was that you had a really low range going up to a really high range reported in the various studies. But because it was a meta-analysis, what they could do was they could make their own estimation looking at the pool data. And that gave them a figure of about 26%. This, to me, is, I think, a fair, more realistic number in terms of what's the proportion of delirium that we see in stroke patients. Now, why is it important to recognize delirium? What exactly are the implications? So again, let's start off generally. And what we know generally is that, unfortunately, a patient who has delirium, independent of all the other things that are going on with them, is at risk of increased mortality, is at increased length of stay, and usually will end up in an institution at discharge. Excuse me. Now, the unfortunate thing is that delirium doesn't end during their stay in the hospital. And the likelihood is that someone who has delirium in the ward is going to have it present at 6 to 12 months. I'm just going to stop for a while.
CT, Radiology Department. Med response, CT, Radiology Department.
Okay, that was a Met response for the Ballarat Hospital, if in case anyone would like to chip in and help out. Now, implications of delirium and stroke. If you're looking at the same sort of analysis points, you find that it's generally, it fits. Meaning that if you have a patient who's suffered delirium while they were in hospital for a stroke, the chances are that they're going to have an increased mortality, whether that's during the admission itself or out at 12 months. They're going to be in the hospital for longer, and they're more likely to be discharged to a nursing home. What is, if any, the cognitive outcome of someone who's got delirium? Now, one of the things that I was taught when I was training to become a physician was that delirium has a very negative impact on someone's cognition. So if you've got someone who has dementia, they're admitted for delirium, it is unlikely that they are going to recover to their baseline cognitive function after they've recovered from the delirium. The other thing that we see very often in clinical practice is that delirium can unmask dementia. So you have a patient who is supposedly well, who comes into hospital for an acute infection, and when they go home, family says that, look, he was fine before this, and now he is not able to function anymore. In these cases where you dig, and if you dig hard enough, you will find that there probably was some form of cognitive deficit even before. Now, excuse me, this is again a secondary analysis of data. Another Met call, guys. Give us a minute.
Met response, Radiology Nurses Station. Met response, Radiology Nurses Station.
All right. Now, this is something where they looked at a cohort of patients with Alzheimer's disease, and they looked to see what the development of delirium did in terms of long-term cognitive impact. And what it basically showed was, as I said, that they used this thing called the IMC score, and in patients who had delirium compared to those who did not, the change in the IMC score was 3 times faster. So what it means is that these people actually deteriorated faster in terms of cognition after an episode of delirium. What is the impact of delirium on cognitive function in a patient who's had stroke? So these are patients whom we think will go on to develop vascular cognitive impairment, a vascular cognitive disorder. And ladies and gents, the answer is that I don't know, because it's essentially a huge void. This is an area of research which is, I think, dying to be explored, hint, hint. So if there are any bright sparks out there who are willing to look at this, I think it'd be more than welcome. What we also know is that, unfortunately, there are dollar implications of delirium, and this is again something in general. Based on previous research and what these two researchers looked at, they estimate, and I think this is fairly conservative, that total direct cost attributable to delirium is in the range of $143 to $152 billion nationally. These are US figures. I tried to look for something similar here in Australia, but I was unable to. I will tell you that it's probably not far off this mark. Why is all of this important? What are the implications to the healthcare system? Does anyone in my room here know what this indicates? Whether... Sorry? So this is something called the aging tsunami. Yep. So the aging tsunami is a real thing. It's going to hit us very soon. And I think easily 30% of us who are listening in on this presentation today, me included, are going to be part of the wave. Now, is this again something that's not going to affect Australia? Unfortunately, no. So currently, we are somewhere between these two figures, meaning that the number of people above the age of 65 in Australia is currently somewhere at about 18%. By 2050, that number is going to make up about 25% of the population. So by 2050, 25% of our population is technically geriatric. So I guess the second question, since I've ended on the focus of how much money this is going to cost, is how many of you think that your patients were properly coded for delirium? We'll end the poll in 10 seconds. All right, and I think that's the poll done. And it seems to be the reverse of the first question. So 2/3 of you think, and I think my group here sort of agrees with the 2/3, that patients have not been properly coded as delirium. What does that mean? It means that, one, I think there's a lack of recognition. That, excuse me. Two, if it is recognized, it probably isn't written down properly or handed over to the nurses or the nurse in charge of the ward properly. And I think the third thing is that by not writing this down, we're actually costing ourselves money. And by costing ourselves money, it means that we're probably not being too wise about this in the long run. Now, let's look at the next bit, which is risk factors and precipitants for delirium. Now, Jimmy Olsen's the patient. Jimmy Olsen's got a broken leg and... Okay, hang on.
Met response. response, Ward 4 North, Med B unit. Met response, Ward 4 North, Med B unit.
You have to take my word for it that this isn't a common occurrence. We have met calls, yes, like all other hospitals, but it's just not this often. Now, the fact that he's on crutches and whatnot indicates that he may be frail. This cliff that he's on the edge of are his risk factors. Now, excuse me, as someone who is on crutches, Jimmy shouldn't be standing at the edge of a cliff, but he'd be relatively safe if Superman hadn't come pushed him over. So that's your precipitant. Now, there are risk factors for delirium. There are multitude of risk factors. I was hoping that I would be able to see this on a full screen, but unfortunately I can't. It's a good thing I'm supposed to know this fairly well. What are the risk factors that you would be most concerned about? The risk factors that you'd be most concerned about is age. With an aged person, you are worried about comorbid factors. So the more comorbid factors they have, the more likely that they are to be on a multitude of medications. The older they are, the more likely they are to have cognitive deficit. I will happily point you to this article here, which was published in 2006, from where I've taken this table. And I think it addresses this whole picture of risk factors in delirium and precipitants very well. Now, with risk factors of delirium, there's of course then the idea of what's the weightage? Does it mean that all of these things are equal, or do you have an increased risk based on certain risk factors? And frankly, the two that stand out are actually dementia. It's not stated here, but age is the other thing. Yeah. Patients, as I said, having medical illness as a risk factor for delirium, I think is more a reflection of the fact that with comorbid features, with comorbid factors, they're usually on more medications. Now, is there a specific risk factor, or is there a specific group of risk factors for patients who've had stroke? Similarly to what the cognitive implications of delirium are in patients who've had stroke, this is a poorly understood area of research. Things that definitely sort of add to the risk are if you have increased age, if you're phasic, if there's evidence of neglect or dysphagia, if there are visual disturbances, elevated cortisol levels. These are factors that have been associated with at least one study with a risk of developing delirium. Interestingly, there are a number of studies that have said that if you have an MCA infarct, it actually increases your risk of delirium. Whether that's a dominant or non-dominant lobe, again, jury's not quite in. Now, that being said, as I mentioned earlier, there are two studies that have fairly looked at whether there are risk factors for delirium and stroke. McManus, whom you may remember from earlier, and his group looked at intracerebral hemorrhage and tachy or total anterior circulation infarct, and felt that it was more likely that a patient would develop delirium if they had these sorts of strokes. And this is a group from the Netherlands who looked at predicting the risk of delirium and stroke, and they felt that risk factors that contributed to the risk of delirium were things like pre-existing cognitive decline, infection, if you had a right-sided hemispheric stroke, if you had a anterior circulation, large vessel stroke, or if your NIHSS score was especially bad and you had the presence of existing brain atrophy. Now again, precipitants of delirium, as I said earlier, you've got risk factors. On the one hand, a precipitant is a trigger. So there are, again, multitude risk factors for patients who have to develop delirium. And what I'd like to say is that if you think back in terms of the stroke risk factors, there are things that are fairly common. So some of the so-called precipitants are things like primary neurological disease, patients who are on multiple drugs, intercurrent illness, and things like environment. What is meant by environment here is not so much the environment that they come from, but where they are nursed in a ward, in the ward. So many of these patients would be in sort of high dependency units, things like a stroke care unit or an ICU, and that unfortunately is also known to increase the risk of delirium. One of the major things that sort of brought about a lot of interest is actually the role of medications. Excuse me. So there is a list of drugs based on anticholinergic activity. Either one of these links will take you to these list of drugs, and based on the anticholinergic activity of certain medications, you can sort of figure out what the risk of delirium is. So if you look at it, it's a fairly commonplace list of things ranging from antihistamines, antispasmodics, benzos, analgesics, diuretics, and it's really frightening in the sense that a lot of these medications are things that elderly patients are very often put on. Now, how do you recognize and screen for delirium? So there are three major types of delirium. So you've got the hyperactive Cruella de Vil, who is, sort of really in your face, agitated, hypervigilant. And this is the sort of patient that all of you guys would remember, because they're the ones who upset the ward and disrupt things around them. But more than that are these patients who are hypoactive, just pausing for a while.
Met response radiology CT, all clear. Met response radiology CT, all clear.
So that's one Met response sorted. We just have to wait for that repeat chime on the other two. Now, these patients are the ones who are lethargic. They are less active, and unfortunately, they are the ones who are missed and therefore at higher risk. More often than not, however, what you're going to be seeing in your wards are the patients who are mixed, who are probably hyperactive 1 minute and hypo the next. Yep. Now, these are the types that you'd see of the delirium patterns. How would you recognize this? I think I'd be vigilant for these sorts of things. So perceptual disturbances usually take the form of illusions or hallucinations. So if you have a patient who tells you that, I've been seeing people walking in and out of the ward all night and I wasn't able to sleep, that's not American Horror Story where they had it in the hospital. It's not ghosts sort of walking around. It's an illusion or hallucination. An altered sleep-wake cycle is another very important thing. And so again, these are the patients who've been up all night screaming and the rest, or walking around, wandering, making a nuisance of themselves because they're trying to climb into the next patient's bed. And in the morning when you go to see them on your rounds, they're sleeping. So again, that's another warning sign. There are emotional disturbances that you have to worry about, and there's a lability. So there might be fear, paranoia, they might be anxious or depressed, they're very irritable or apathetic, they might be angry or euphoric. So as I said, there seems to be this whole spectrum of emotional disturbances that might actually be masking an underlying delirium. What I would say is that it's, I think, our duty to be sort of vigilant of all of these things. There are two standard tests that are used for screening of delirium. The first is called the Confusion Assessment Method, CAM, and the other one is the 4AT. The Confusion Assessment Method is by a researcher named Sharon Inoue. Stopping again for just a minute while the chimes end.
Med response 4 north, all clear. Med response 4 north, all clear.
So that's the second MET response dealt with. One more. So she is someone who's done a lot of work into delirium, and this tool was as a result of her research in collaboration with her colleagues. This is a newer tool that's come out of, I think, Glasgow, somewhere in Scotland. I can't remember whether Glasgow or Edinburgh. And it's also sort of gaining popularity. As I said, these are just screening tools, the recognition of delirium. Obviously, the more often you use it, the more comfortable you're going to get with being able to assess a patient confidently. So, what do we do in delirium once we've sort of recognized it? The first step, I'd say, would be evaluation of the patient. So you've got your general evaluation of the patient, you know, their airway, breathing, circulation, their GCS. You check their vital signs, and you'd immediately look for evidence of an infection, because that's one of the major precipitants. So this would be lung, bladder, lines, which are very often overlooked, I think, and skin. You can evaluate for presence of pain, whether this is pain in the back, in the knees, a headache. You're going to look for evidence of bladder or bowel disturbance, whether this is incontinence or constipation. To me, this is a very important step, which is the review of medications. And patients with delirium have probably been in the hospital for a while, so you'd like to start off, I think, by reviewing recent investigations. These, I think, are just the sort of basic investigations that you would do for any patient with delirium. This is a sort of a dementia panel, which you would do all the same just to make sure you're not missing anything. And the last bit, in terms of an EEG and CSF analysis, I think are only required if you suspect that there is a CNS pathology. I don't do these routinely in terms of an EEG and getting a lumbar puncture. What are the major management steps in someone with delirium? I think that frequent orientation is a very important bit, and people who followed me on my rounds will probably vouch for the fact that it's one of the things that I do religiously in terms of orientating my patient to time, place, and person. You want to ensure continuity of care, and I know that this is a huge problem because it's not often that we're able to ensure that continuity of care is something that we can offer to all patients with changes in rostering and whatnot. You want to make sure that your patient has adequate analgesia because, like I said, pain is one of the main things that can trigger delirium, but at the same time, you want to make sure that they're not over-medicated, that they're not victims of polypharmacy. You want to encourage mobility, get them out of bed, get them going to the toilet themselves as much as you can. But again, guys, it's a question of what is your patient able to do and how safe are they when they do it. Many of our patients have hearing impairment and visual impairment, so we should make sure that if they have hearing aids or if they wear glasses, those are available to them while they're in the ward and that they're in good working order. You want to make sure that they're not constipated. You want a good sleep pattern, so it's a question of sort of helping them wind down at the end of the day and making sure they're as comfortable as possible when they go to sleep. You want to maintain good hydration, so that's fluid intake. Get family and carers involved. Tell them what's going on. Make them a part of your whole orientation plan, which is what I do. And look at avoiding complications. So, things like immobility, making sure that they have adequate nutrition, making sure that they don't develop pressure sores. You want to make sure that sedation is not liberally used as it is in most cases. And where available, you'd like to liaise with old age psychiatry. Now, the list of don'ts is much shorter, but you'll see that there are lots of things here that we actually do fairly routinely. Patients who are at risk of delirium or who are in delirium should not be catheterized. Restraint use is not something that is generally done here, but I think in many parts of the world it's still fairly common. You shouldn't sedate your patient routinely. This is unfortunately something that I see done fairly routinely here. And this is a pattern I think we need to learn how to break. Don't argue with the patient. Again, this is, I think, stretching the limits of our patients sometimes because it can be very difficult. You're dealing with a ward of 20 patients. You're caring for 4 or 5 of them. 3 of them have delirium. It takes its toll. We all know this. But I think there are sort of management principles that we can put into place to sort of prevent ourselves being in situations where we are caught in arguments with patients. Now, what's the role of pharmacotherapy in a patient with delirium? Surprise, surprise. There is no evidence to support the use of routine antipsychotics in treating a delirious patient. There is a planned Cochrane review. The protocol is available, but no results have been published as yet. I think the protocol was available from last year. Now, again, we go to a meta-analysis, and from over 10,000 eligible records, they identified 19 studies. They have 2 groups, so in the first 7, or rather in one group of 7 studies, it was looking to see whether antipsychotics would help prevent delirium after surgery. There was no significant effect. So, no role for antipsychotics in trying to prevent delirium in patients who are supposedly susceptible to it. Now, from all of the 19 studies, they showed that use of antipsychotics was not associated with a change in how long the patient was delirious, how severe, how long they were in hospital or the ICU. Yep. And with meta-analysis, of course, the problem is that there is a degree of heterogeneity, and the reviewers here have confessed to the fact that there was high heterogeneity among studies that they looked at. What's important to sort of note, however, is that there was thankfully no mortality that was associated with use of the antipsychotics. So, third question, last one. Based on whatever it is I've told you, how many of you think that your patient was managed, or your patients were managed correctly? Are my guys, they're all shaking their heads here. Unanimous? I'll duck out if you want to take a private vote, no? Poll comes to a close in 10 seconds. And done. So, majority, I think, basically felt that delirium was not properly treated. And I'd like to think that that's a good starting point. So I'd like to think that, it's a recognition of the fact that delirium was probably not properly managed, whether it was a question of it not being properly recognized, or whether it was a problem of it not being treated properly, perhaps with overuse of antipsychotics or pharmacotherapy. More for us to discuss, I think. So, ladies and gents, what do I think I'd like you to take home from this? First point would be that I'd like you to recognize that this is an acute clinical syndrome. And the characterization is one of a reduced level of consciousness, and that the cause fluctuates. It is a common condition, but unfortunately it often goes unrecognized. There are significant short-term and long-term effects associated with delirium, so we should be doing something about improving our recognition of this. And the last bit would be that non-pharmacological treatment of delirium should be our preferred route. Now, that's my last slide, so thank you very much for your attention. There's a question coming in. This is from Belinda. You're really stretching me on this, Casey, because... So, hi Ramesh. This is from Belinda. Interested to hear whether on previous slides stating no evidence for routine antipsychotics and delirium, is this just meaning for prophylactic use or use of antipsychotics to manage agitated behaviors of delirium in general? So I'm just going to bring the slide up again. So, Belinda, this is an answer to your question. What the meta-analysis showed was that it actually covers both of the questions you've asked. So, whether it's routine use in terms of preventing, no benefit, and whether in terms of whether use of antipsychotics was actually able to change duration, severity, or length of stay in delirium, again, there was no benefit. Now, look, I think the reality is that there is a role for delirium in management of patients who are either a danger to themselves or a danger to the others in the ward, whether this is members of the staff or whether this is other patients. In patients in whom delirium has affected their ability to be treated, I would also use antipsychotics. What I would say, however, is that that would be my last resort. I hope that answers your question. I'd use the CAM. I'd use the CAM. That, again, perhaps my bias because I'm used to it, as in I know it better. That's an excellent question, Amanda, and this is something that I actually have a bit of a grouse with. So, recognition of dementia in a patient who has delirium, I think, is important. As I was saying, I think you will come across in your practice where you have a patient whom the family considers as being normal, who comes into hospital with an acute medical condition and then develops delirium. I think that should set off alarm bells in the sense that look for dementia and look to see if it was pre-existent. So you'd really have to quiz family, and as I said, the more you dig, the more likely it is that you're going to find something wrong. Now, in terms of the effects of delirium, since, as I pointed out, it can be something that's there up to 12 months after discharge. So then when do you safely say that this patient is over delirium and can now be diagnosed with dementia? Tricky one. I think it depends on how much of a dementia screen you're using and what domains of cognition are affected. I would wait, I think, at least 6 months before I'd be comfortable about making a diagnosis of dementia that was not previously detected in someone who had recently been admitted for delirium. That would be my answer, I think. Thank you, Sharon, and thank you to the previous person as well who said it was a worthwhile. Sharon, I'm thanking the people first. I'm thanking my audience. I'm being interactive here. Yes, Daphne. Okay, Daphne, can you discuss delirium in stroke patients versus new? So again, I think this goes back to the previous question in terms of, we know that delirium in stroke occurs, we think it probably occurs in about a quarter of our patients. We know that cognitive deficits after a stroke also occur. The numbers from memory, if I'm remembering this correctly, I think if you have one stroke, the risk of developing dementia is 1 in 10. If you have multiple strokes, it goes up to about 30%, so 1 in 3. Generally, your risk of developing dementia post-stroke is twice that of someone who's never had a stroke. So when in the time frame then can you safely say that someone has dementia if they've had delirium post-stroke? I don't know. What is interesting is that there was a study somewhere in the 1990s from, I think, Finland, where they showed that the highest proportion of patients with cognitive deficit was at about 6 months post-event, where it was 9 times more likely for a stroke patient to show evidence of cognitive deficit as opposed to someone who has no stroke. When they followed these patients throughout to 2 years, that number actually fell. So at 2 years, it was just double the risk, and I think that's what you're looking at. I hope that's answered your question, Daphne. Matt. Questions from Lisa, right? So, again, a bit tricky. The main thing I think is that your diagnosis of delirium in a post-stroke patient is not entirely language dependent. And as I said, if you're dealing with someone who's, say, got fatigue, they're going to be mostly flat throughout the day. With a patient who has delirium, it's something that fluctuates. So they may be fairly normal and talking to you 1 minute, and then, as I said, 1 hour, 2 hours later, they're sort of all flat, not responding. We've had patients in similar situations who've had met calls because, the question was, there's something wrong with this patient because they're not responding. So I would say that, to me, go back to the definition of what delirium is. Go back to what the sort of diagnostic criteria are. and you would still be able to pick up someone, even if they have hypoactive delirium, in the setting of a stroke that's affected language or is causing fatigue. More questions? Can we have a copy? Thank you. Karen, thank you very much. And copy of slides will be available to VS, and they will upload it. Thanks, Deborah, and thanks, Susie. Sorry, Amanda, I didn't realize that you couldn't see the questions. Okay, so I guess that's kind of it. Probably no more questions. The slides will be available to the VST, so guys, you can just look on the website and it will be there. Thank you very much for dialing in.